But today, since morning, we have been discussing so much about the different types of complicated ptosis. So I still believe that for ages we have been using either the frontalis sling that you can see here. Oh my God. ये कंट्रोल कर बंद कर दीजिए ना. Okay, so since ages we have been doing this surgery, which is a very nice form of doing a surgery with a Fox pentagon, and we really could get good results. But we have seen multiple drawbacks, which we have already discussed in the previous session regarding the lid lag, the leg of tumors. Sometimes we get the lid lift off, and also the most important, when we use a fascia lata, it is basically what we need. We need a different donor site. So to overcome all this disadvantage, so in lieu of a graft or a suture material, now what we prefer using a frontalis flap advancement. So this is one of my patient with blepharophimosis. Can you see when the child came, his chin he used to lift up to see, and we had done a pretty good surgery. I mean, we have addressed all the 4 tetras of the signs and symptoms of the blepharophimosis. But what I was not liking, that even after 4 years, when the child comes back to me, you can see this scar. So I was thinking something where I can have a much better technique, where I can do a procedure wherein there will be no scar in the forehead, and which is basically a one-time procedure, and secondly where there is no leg of tumors. So this is how we do frontalis muscle slings advancement surgery. And this is what I usually like to stay mainly in the lateral part of the frontalis muscle, because we know approximately 2.5 millimeter from the midline we have the supraorbital blood vessels and the nerves. So in order to avoid injury to this group of the vessels in the nerve, I usually make an incision, usually laterally, and then as usual the routine lid crease incision, and after doing the lid crease incision we expose the tarsus. Let me see if I can go a little fast. Expose the tarsus, and then you go just below the orbicularis plane and you try to dissect out. So once you start dissecting, go approximately 1 centimeter above the forehead, and once you dissect it, you can see the frontalis muscle. This is the frontalis muscle you will be seeing. Just separate it a bit without disturbing the orbicularis, and then you suture the tarsus, and you have to do a little overcorrection on the table, because even for normal ptosis, what I have seen, supine and sitting position are 2 different results. So I usually prefer doing whatever is my target amount of ptosis correction. I usually prefer doing approximately 0.5 millimeter overcorrection on the table when the patient is in the supine position, and every time I usually make the patient sit down and assess how much amount of the ptosis has been correction. And this is a child after the surgery, and this is what you see. This is pre-operative and this is post-operative. Look at the forehead, there is no scar at all, and just a few sutures, the lid crease suture. This is just on the first post-op, and the best part, this is what I was insisting. So even in the early post-op, you will not see leg of tumor. So when they sleep so peacefully, so chances of all the complications that we are having, it is not there. Then I started taking up more cases. This is one of the adult. If you look, the left side is very severe ptosis and the right side is a moderate ptosis. So I have planned to do a frontalis muscle flap advancement for the severe ptosis and the LPSR for the right side. So same technique, what you do, you expose the frontalis muscle. You make an incision just below the orbicularis, expose, you just try to separate it with a blunt scissor, go approximately 1 centimeter above the eyebrow, and once you get this, you can see the frontalis muscle is little reddish in color. We know orbicularis is also reddish, but when you compare the frontalis and orbicularis, the frontalis is little more redder in color. And then what you do, you suture it to the tarsus, and then you see on the table. So doing a ptosis under local anesthesia becomes very easy, because on the table you can check. And this is a patient after completing, I usually made him sit on seat, and then I was assessing, sorry, I have to go fast because the left side corrected, and the same procedure right side I have done, but I have done the LPSR. So after I wanted to compare the results between the LPSR and the frontalis muscle advancement, and then when you see here, this is a patient on the second post-op, And this is a selfie that he has sent it to me 10 days. And what he writes is, ma'am, my glass bar has also reduced. So this is a clear-cut example where we see that when there is ptosis, it affects the vision, right? It affects the refractive error. And now a very recent picture he has mentioned the glass bar has further reduced. So this is how it is improving the quality of vision in this patient. So another small child, severe ptosis on the left and moderate, so LPSR on the right and the frontalis muscle. You can see so beautiful correction and you do not see any leg of thunderous. Taking a more challenging patient,